Introduction to Nursing Concepts, Accidents, Part 2. This is Martha Olson. So as we left off, we were talking about different types of chairs, how we can appropriately use them, not to be a restraint, but to help us to keep our patients safe. When we look at some of the legal implications, we have to know our facility policy. We know that it has to be clinically justified. We can't just do things because we want to make it easier on ourselves, and we have to have that order from the physician. When you get into your mental health classes, we will be talking about how this will be different on the mental health unit. We actually even have a simulation lab that works on restraints because it's very different sometimes in the mental health unit. Again, you're going to continue to assess and document what are their behaviors. How are they tolerating being in a restraint if you do have to use it? What is the skin underneath? Because many of your patients that are rubbing and twisting and turning their extremity trying to get out of that restraint are causing a lot of skin damage. And then if they get that twisted, they're cutting off circulation because it's too tight. And so you have to continually assess and document all of those things. We have to remove the restraint and perform range of motion, offer a drink, offer toileting, get them up and ambulate them on a periodic basis depending on what your policy says, usually every 1 to 2 hours. So you can't tie somebody down in a restraint and just leave them there. When we look at the quick release tie, your book does a good job of showing this, how you do it to the bed frame, so that you should be able to give with one quick yank, get that loose in case there's a fire, in case you have to get that patient out of that restraint very quickly. Let's say they need CPR or they're vomiting or something where they're going to aspirate or have more problems. The picture on the right is just a kid in 4-H that probably learned how to do the quick release tie for the judge when he took his bucket bottle calf up to the county fair, and that's exactly the same type of tie that we use in healthcare. So if you were in 4-H, you might know how to do it already. As we look at a chemical and a physical restraint, things to think about. Can we delegate restraints? Can we delegate to a CNA the task of checking on restraints, applying restraints, taking them out of restraints? And then in your skills checklist in the Potter and Perry book, it has many of the clinical decision points that you would want to read and consider. This patient is intubated, he's got a lot of tubes, and it does not look like they have him restrained, but it is a consideration when your patient is intubated, because many times that is very irritating to them and they will extubate themselves or pull that tube out very quickly if you're not watching them. And so sometimes restraints are used in those situations. When we document restraints, we want to make sure, again, their behavior before, so that when somebody audits or looks at that chart, they say, yeah, they did need restraints used. They were unsafe. It was not a safe situation. And then how are they doing with that on? What are the alternatives that we tried? Before you put somebody in restraint, you should have tried many other things to help keep that patient safe. And if it just is not working, then your documentation of what you did try before helps support why you use those. The type. Are they wrist restraints? You know, is it a different type of restraint? And then where did you put that wood extremity? Because maybe you only restrain the hand that is pulling at the catheter or the IV or the nasogastric tube, and they've had a stroke and their left hand is not able to pull or need a restraint at that time. And then all the times that we release those to do activities of daily living. You want to make sure you can get 2 fingers between the restraint and the person, that it's not on too tight. And then again, we have to offer our drink and activities range of motion. So a use of restraint must reduce the risk of injury. We have to document that. Prevent interruption of your tubes or things that they have going on. Removal of life support. Decrease the risk of injury to others. And that's usually in the mental health unit. When somebody is out of control and they're hitting and punching and very aggressive, that might be when they get the restraint chair in mental health. When we think about an example, the client is newly admitted, there's a key word, to the hospital, appears disoriented. There's a concern for the client's immediate safety. You're considering the use of restraint. You know that a restraint requires always the physician's order. We can't do that just because we want to or it's convenient for us. As we look at some of the alternatives to restraints, box 2713 gives some good ideas of some of the alternatives that we can use. As we look at side rails, we have to have a release to leave them down. So if somebody says, I do not want my side rails up, we have to get a release in most cases. The other thing that you think of with side rails is anybody you've given a pain pill to or something that's going to alter their behavior and cognition, like an anti-anxiety medication. You would have to have the side rails up. If we've given a pre-op med, we've given them their Demerol before surgery, we need to have those side rails up legally. If we have all 4 side rails up, it is considered a restraint. So what we typically do is have 3 of the side rails up and then push the bedside table on the side that has the side rail that's down. We never want to tie restraints to the side rail, because if you put the side rail down, obviously then it's going to change the position of that restraint. In looking at the end of the chapter, our seizure precautions, how do we respond? What do we do with that? How do we prevent injury during a seizure? I've got a video that we will watch in class. We know that as we think about the priority, what we do first, if your patient is in bed, we would want to assess for safety. Is the side rail up? Can we turn them on their side so they don't aspirate? Put the call light on. Identify the time that you noticed that this seizure activity started. We never want to put anything in the mouth. It used to be that they said put a tongue blade in the mouth so they don't bite their tongue, but we found that actually they have more oral mouth damage when we do that. So we just turn them to their side so they don't aspirate. Prevention of this is by giving them their anti-seizure medications on time. Anticipate a seizure and be prepared for it. If they have a seizure history, usually we put padded side rails on the bed so that if they would have a seizure, they aren't flinging their arms against the side rail getting injured. If they are ambulating or in the bathroom, we try to get them to the floor, protect that head. Again, pad the side rails. If you can, loosen the clothing around the neck. And when we look at the clinical decision in the skills checklist, it says if you do not notice the seizure activity, treat them as a closed head injury or a spinal injury. So if you don't know if they fell and wonked their head really good on the floor, treat it in the most serious manner until it's ruled out otherwise. When we look at elopement, that is a patient or a resident leaving your facility. It happens very easily and it happens very quickly, and so you have to have your plan in place as to what you want to do. What is your facility guidelines? I know a student a couple of years ago said that she lives in a small town, works at the nursing home, and they have a group of people in the community that if the nursing home calls and says Mabel is gone, we can't find her, this group of people goes out and they will canvass the community, and they are a volunteer group that would help them find that person. I know not long ago, I think it was in Humboldt, there was a lady that got out of the nursing home and froze to death. And so, you know, this does happen. Most of your facilities have a code that you have to push at the door to be able to get out without it alarming. But these patients sometimes can be very tricky. They go out with family, or they walk out with maybe the UPS guy that brought in some packages, and they don't know that they weren't supposed to come out. Never leave your keys in your car. If they get out, many of them will get in your car and go for a very nice joyride some afternoon. Make rounds often. Know who your residents are and where they typically like to be during the day so that you can notice if they're gone earlier. In the hospital, it's a little harder because we don't have a code going out, and sometimes patients just go for a walk in the hall and sometimes they don't ever come back. So it is a consideration. When we look at the evaluation of that, we have to think of how we can keep that environment safe. Are their expectations being met? Are they free from injury during their stay at our facility? When we look at our documentation, if your patient would fall out of bed, land on the floor, and you find them on the floor, confused, incontinent of urine, their left leg is internally rotated and shorter, he complains of pain to his head and hip, What is your first priority? Hopefully you're starting to think the head injury is my priority. Do they have bleeding from the head? Airway, breathing, circulation. They're breathing, they're talking to me, they're moaning in pain. I leave them on the floor because with that hip, it's probably broken. Rotated and shorter is usually an indication of a hip fracture. So I would want to get plenty of help. You're going to call your physician. You're going to call the family of this resident in the long-term care or in the hospital. We would transfer them to the hospital if they are in the nursing home. And then you lastly would document and fill out your incident report. What happened? How did you find the patient? What were the vitals? Who was notified? What was done? No matter what happens, that incident report is made, but remember, we never put that on the chart or in the charting. As we look at special considerations for our aging adult, we think of the falls, our musculoskeletal changes, the weakness, the nerve changes, Parkinson's, the shuffling of the gait, sensory changes such as neuropathy, where they don't feel that they bump their toe and it's bleeding, or they've got problems. And then with genitourinary, that sometimes hurrying to the bathroom because they have a little bit of stress incontinence. All of these things can contribute to injury and falls during hospitalization, or even for those of you working in long-term care and home care. These changes can become very significant as well. As we look at falls, we think of the common factor of getting to the bathroom at night. Orthostatic hypotension, when they get up quickly, they usually have that urgency to void. Lights are often decreased or lowered, dimmed at night, and they can't accommodate their pupils quickly to get you into the bathroom without problems. As we look at our wheelchair safety, we think of the different types. Make sure you are familiar. We are assuming you've had this in the CNA class, how to appropriately lock them, where to position that. Remember the arms, the armrest can come off, and those feet guides can come off or be pushed off to the side as well. So the patient is not bumping their legs trying to get into the wheelchair and hitting the footrest. The motorized scooter, they can tip over very easily, and sometimes you get people that are using those that become overconfident or drive them too fast, and they hit a bump or do something, and they can flip them and get injured in that regard. As we look at hip fractures from falls, we know that a large percentage of our hip fractures that come into the hospital never regain their previous level of functioning, and so a fall can sometimes be that downward spiral for a person that maybe lived independently at home, but now they are with an injury, living in the long-term care. They become depressed, they get blood clots, and it just seems like their quality of life diminishes significantly after that. As we look at evidence-based practice, your book talks about rounding versus purposeful rounding, hourly rounding. And it talks about when you round, you can walk in the room, see they're sleeping, and leave. That's rounding, and that's okay. But purposeful rounding is where we actually toilet turn and make sure that their possessions are in close reach for them so that they are able to get what they need. And evidence-based practice in your book talks about why we are doing that, and we're hearing more of that as I go to conferences and work in the hospital, different things with purposeful hourly rounding being done. With our pediatric population, make sure that when babies go home from the OB unit or even dismissal from the hospital, that they are going home in a safe car seat, that it's properly installed. Children up to a certain weight and height, depending on the regulations, have to be in a car seat. So the one on the left is actually more of a toddler seat, and they are very helpful in preventing injuries to our pediatric population. Other specific injuries, we think of falls, drowning and poisonings. There are fire deaths, especially at Christmas time and at night with Christmas trees and use of matches, fireplaces, kids falling into fireplaces. And then in the summer, a lot of these houses now, people are building fire pits, and we're seeing some of the injuries from that. We also need to go back to our growth and development class and think about what is the developmental level of our person. And then our reference today is our Potter and Perry textbook. Thank you.